Thank you. We're going to call the meeting to order, and the clerk will take roll, not that it's necessary, but we'll go ahead and start moving forward. Any senators want to sit at the table here? Senator Johnson, we saved your seat here. Well, the last meeting that we had when you were going to give us information, we had the Milliman group here, and it left only 10 minutes, and I think you have more information than 10 minutes to provide. And so that's why we asked you back. And it's a big job that you have in front of you, and we have a lot of questions. But first of all, we'd like to have you, I know you handed out some information, and if you'd like to go ahead and start, and I don't know whether Director Palmer, you or Director Steer want to start first, but please proceed.
Thank you again for inviting us to come and provide you with an update, and we will walk you through. The document that I'd like to start with is the one that actually has the 16 items from CMS, and I will walk you through and kind of move you through those. The first item is a communication plan. We have been working to develop a very robust communication plan for managed care, and I'd like to highlight some of those areas for you. And we received previously, and we do thank the legislators for this, we have received some feedback on our call centers. I'd like to emphasize the call centers are not only the Iowa Medicaid Enterprise call centers, they're the Hawkeye call center, as well as the MCO call centers. The feedback helps us. As most of you know, we have been doing secret shopping with the call centers. One of the things that we have done is that we have prepared scripts and guidelines to all of those call centers to ensure that we can answer any new questions that are arising. And believe me, daily we're getting different questions coming in and we're answering those, as well as to respond to feedback. We get reports on abandonment rate, we get reports on just overall call length and concerns and issues, and we monitor those daily on all 5 of those call centers. And if that references both 1 and 2 of the 16, in addition to that, we have done some updates not only to our website, but also to the Hawkeye website in terms of frequently asked questions, customizing those questions by the member type that we're serving. And I think that has really helped to beef up a lot of communication. I would welcome you all to be paying very closely to our website. On there, we have a whole litany of informational letters regarding things like prior authorizations, just questions that will come up with our providers. To make it easier for our providers, our informational letters have what's called an MC code on the very back of them. That's managed care. So you could very easily sort through and pick up the managed care informational letters for the providers. And again, it's another way to communicate with our providers to make sure they're receiving timely updates. We have started and redeployed a Medicaid e-newsletter that goes out to stakeholders and providers. It has very timely information on it. We are launching a quarterly e-newsletter to the Hawkeye stakeholders and members as well to robustly build that. We recently have also put on, and that I would welcome, we did a bunch of trainings. We did 11 states, 11 cities or counties, excuse me, not states, we'd be all over the world then, that we went out and we provided member and provider training. On our website, we're pleased to announce that we actually have webinar videos that now members and providers can look to, talking about the change, providers selecting an MCO, making a change for your MCO, and after the MCO enrollment process. They're very user-friendly webinars, and again, this is part of our communication plan. And then finally, we have been doing some recent mailings. We have sent out the WellCare reassignment, and as you know, those letters have gone out to all the WellCare members. And then anybody that is newly enrolled, as you are aware, we get newly enrolled monthly. We have sent those out to those members as well. And then we are also launching social media to ensure that we have a robust communication both on Facebook and Twitter so that there are commonly asked questions, also potentially linking them to maybe the webinars we have on site as a future growth that we're going to try to do. So that is a very robust communication strategy and plan, as well as our call centers. In terms of member selection process, again, it's part of the communication plan. Our call centers are ready to help with members selecting their MCOs and choosing those, and that is part of this communication strategy. 4, 5, 6, and 7 are related to the network adequacy, and I will call your attention to the blue sheet. This is the famous blue sheet that we look at. As you are aware, right now, we have over 93,727 contracts. It's above 100% because we're leveraging the commercial markets that have agreed to sign and serve some of our Medicaid enrollees. So we have a very robust network. We are monitoring that on a almost bi-daily, every other day with our plans to ensure that they meet the network capacity and network requirements that CMS has asked us to meet, not only in primary care, but within the waiver services and the behavioral health services and long-term services and supports. So this is the update. You can see that overall, we've also been monitoring the out-of-state providers, and keep in mind that many of the out-of-state providers are contracted to serve one member at a time. You will still be able to serve one member at a time with what's called a single case agreement. So we are very aware of the need for those single case agreements for out-of-state providers, but they are reaching out to the out-of-state. So since December, the contracts have more than doubled. Some providers have not signed, and this is one thing that we are finding right now. We do have some providers that are kind of sitting there waiting for CMS approval. The state is ready. Iowa is ready to move forward. We do have a couple providers waiting for the CMS approval. Members can choose their MCOs on who their provider has contracted with. And then members can change for any reason also by May 18th, which I think is very important as well. In terms of, that is where we are with the network on the 16, 4, 5, 6, and 7 of this handout that we have. 8 is one of the other things as part of our communication is that we have done outreach to a lot of the associations. When we are doing provider training, we've had a couple associations request specific training, like to the behavioral health providers, or we've had it to the Iowa Association of Community Providers, specific training on how they bill, their uniqueness. We know that it's very important for the waiver providers to have that training. So we've outreached to them. We've had meetings with the FQHCs as well, and concerns and issues for implementation. So we've done a broad array of outreaches to associations, and then even individual meetings with the various executive directors of the various association and provider networks to make sure they understand this. If there's concerns or issues with this transition, that we address those as quickly as we possibly can and to mitigate any concerns with that as well. When you look at prior authorizations, again, we have, as part of our communication, and this is number 9 and 10 of the 16, we have implemented an informational letter letting them know about prior authorizations and how those prior authorizations will be acknowledged. Out-of-network reimbursement will be for 100% for the first 30 days. Current prior authorization will be honored for 90 days. And the lack of a prior authorization will not prevent claims for payment for first 30 days, with the exception of our pharmacy claims. And then during March, prior authorizations are encouraged but not required, with the exception of our pharmacy. And then retroactive review of medical necessary permits. However, we have to be able to move forward with any kind of thing. So we have communicated all of the prior authorization communications multiple times with the associations and with members, and continue to reiterate those standards for our members to ensure that there is a better understanding on how prior authorizations will work during the first 30 days and then moving forward with transition. In terms of case management, which is 12 and 13, key to this, we have currently LTSS members are assigned a case manager, oftentimes that they have a limited resource. One thing that we have done is we have reached out to the 70 case management agencies We have asked them, are you going to continue with your case management after we go to managed care? And if not, we have a list of those. Once we have had all of that information, we reached out to the MCOs and gave them contact for those case management agencies and the members that they are going to be working with or continuing to provide case management to support them with contracting. As you are aware, members can maintain their current case manager for 6 months, no matter where they are with the MCOs. Many of the MCOs are entering into agreements with the current case managers, and they can choose to continue those case managers with those clients, again, as I said, for 6 months from the transition to managed care. The MCOs are entering into agreements with and paying the case management entities wanting to continue at least the rate that they were paid in July, and case management entities that don't want to continue to operate, or if individual case manager is no longer available, the MCO is working to reassign those to an individual community case manager at this point. And then we continue to monitor the case management to ensure that there's a smooth transition so that the case management will move from the current case management into the managed care case management. And then we continue to communicate with the case management agencies to ensure that they understand the transition into the case management. In terms of 14 is the Ombudsman's Office. We have provided support for them on their policies and procedures in terms of just some technical support for them. In addition to that, we have set up an entire onboarding and training for the Ombudsman's Office. We've had them over with member services, understanding how member services works, reviewing our appeals process. We also have meetings scheduled with the Ombudsman's Office and the MCOs to understand what the MCO's grievance and appeals processes are, so they're linked into that. We're also doing training with the Ombudsman's Office on waivers. We know that waivers are very unique, and that population is very unique, as well as any kind of other questions or technical assistance we are making available, and we have a full schedule for them in the next, well, we've had a full schedule for them for a while, but we will continue that. And then we have set up a monthly meeting with the Ombudsman's Office, or as needed for us. And then we have assured with direct communication with our member services, so that if the Ombudsman's Office is receiving calls right now with questions and issues, we're linking them to our member services to ensure that we have clear communication with the members that are calling the Ombudsman services. 15 was related to one of our MCOs wasn't able to share data files between us and their pharmacy. We now have that taken care of and resolved, and there's no issue with data transfers between the state and the MCOs. And 16 is the contract amendment. The contract amendment is with CMS at this time, and it is being reviewed. We do believe we have met the 16 items, and they are completed. 2 of them are being monitored right now with CMS, and that is our network as it continues to grow, and the implementation of the training and support that we're providing to the case management organizations and with our MCOs to ensure the smooth transition with case management as we go live March 1st.
Thank you. Do you have comments, Director Palmer, or do you want us to just move to questions? Okay. Thank you, Mickey, for that presentation. I just have a couple of questions, and I'll open it to the other members here. You talked a little bit about the network, and I live up in the northern part of the state, and I got a call yesterday from someone that had called the 3 MCOs. This individual gets their services in Albert Lee and through Rochester, through the Mayo Clinic. 2 of the MCOs did not know what the Mayo system was, which I think it's a very well-known service. And I know because Rochester's so close, but I think people have flown in from around the country there. And the other thing was that none of them have signed with that entity, and the only one that indicated that, there was only one that indicated they may sign. That was 2 days ago. So I'm not sure if there's a network around the fringes of the state that is being impacted, or if we are just dealing with only providers in Iowa in your reference to your totals. I think in past you have shown some out-of-state, but a lot of these individuals are impacted. They've been receiving their services, and so are they looking at getting providers in different areas, or?
If they're we received a call, I think, regarding an individual that's getting their care at Mayo Clinic, and they were very concerned about wanting to continue with those providers at Mayo Clinic. We did outreach to the MCOs and requested they look at a single case agreement with that one member. We were made aware of a member that has that need to continue those providers. We at the state do a single,
I can give you way more than one
Right.
member.
Well, I'm just
I can
saying
give you a list off
Okay.
the top of my head of individuals
Yeah.
that I know, so.
Yeah, and we are reaching out to the MCOs and talking to them about the Mayo Clinic, and that they do need to be working on negotiations with the Mayo Clinic. We do have some providers now out on the fringes of the state, if you will, in terms of networks that they have actually contracted with.
My second question would be, we had the hearing about the beds and the communication about mental health beds and how we're doing the tracking system. And at that hearing, we heard from a hospital that said they had an individual in their hospital, and for 3 days, after 3 days, they were stable, but no one would take that individual because of behavioral issues, fear of whether they would be covered under managed care and to what extent they would be covered. When you visited with me, you said that they would be covered as long as they would be there. And I just wanted to have you restate that for me, that after the managed care organizations come into existence after whenever date they start, that a person that would be in a hospital would then have that payment covered until there was another place to take them.
So one of the things that the managed care organizations will be offering is care coordination, and one of the goals for managed care is to move members from an acute environment to a less restrictive environment, a community-based plan. The managed care MCOs are paid to move those patients through those networks, so they would continue the care and the payment of that care for that transition.
You're stating that if that transition didn't happen, they would still cover the care of that hospital.
They're responsible for that member's care, yes.
They would still cover the payment for that hospital.
I believe so, yes.
Okay, well, I just wanted that stated. And then the other question I would have on the doctors, we seem to have more doctors having contracts than we have doctors that are licensed. Can you explain that to me? Or is there a cloning process I've missed?
There may be multiple locations for that one physician's clinic, so they could be contracted in multiple locations for the one provider. Thank you.
Senator Johnson.
Thank you, Madam Chair. Thanks to you for being here. I just have a couple of questions. On the pharmacy action, it says that one of the MCOs did not have its pharmacy system configured and tested, but it says completed. So has that been all done, or is it still waiting?
Nope, it's been tested and completed.
It has been, okay. You said, in talking about the network, that a couple of providers are waiting for CMS. Can you explain that? What do you mean there?
Okay, we know of a health system outside of our state that is waiting for CMS approval before they will actually sign a formal contract.
Okay. Do you think it's a good thing that we have had an extra 2 months to try to sort this out?
The state's ready. The state was ready in January. We're more ready now.
Okay. 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 Thank you very much. Thank you, Madam.
Thank you, Madam Chair. Mickey, good morning, and Chuck, good morning. Thanks for being here. I want to start with a couple questions on the network adequacy. last time we visited, I think you said that 45% of providers had signed contracts with all 3 MCOs, and I'm wondering if there's an update today on that.
We're well over 60% of the providers have signed up with more than all 3 of the MCOs, have signed up with all 3 of the MCOs.
More than 60%. Thanks. When I look at the numbers on the first bar here, it says we have nearly 30. Yeah. There you go. Thank you. It says we have nearly 30,000 fee-for-service providers, and we have, AmeriGroup's signed up with 98% of them, has contracts with 98%. AmeriHealth has 99%, and United has 115% because apparently they have people in the private network. So it looks like the MCOs have nearly, 95% coverage of all. It appears they have contracts with nearly every provider, better than 90%. So when you say it was 45 and something more than 60% have signed with all 3 MCOs, it doesn't make sense to me based on these numbers, because it appears that the MCOs nearly have a 95, 98%, 92% with all 3, with all the providers. So I wasn't able to square that last time because these numbers haven't changed. The top bar hasn't changed much since the last time we saw these numbers. It was 45%. So I'm confused about network adequacy based on the numbers you're presenting here. I don't know if you've got anything more to say on it, because I think network adequacy is having as many providers as possible sign with all 3 of these MCOs, so that in my community, I assume my community, there's about a third with AmeriGroup, about a third with AmeriHealth, and about a third with United. And to get the best, the most flexibility for beneficiaries, consumers, being able to have a good, having good coverage by all 3 MCOs across providers. So your numbers they don't make sense to me in how they're presented here. So I remain concerned about adequacy of the network. On the question of case, I don't know if you want to
we would be
clarify
more than
that.
happy to reconcile the situation, get a sense of exactly where they don't make sense, and turn that around so that you would have the accurate information.
Yeah, so network adequacy, I think, is a big deal to making sure we're ready to push the go button, and that's remains a question mark in my mind. On the issue of long-term supports and services, approximately how many people, what's the total LTSS population that we're working with right now, just to refresh me? How many Iowans are in that category?
Approximately 25,000 Iowans that are in long-term case management.
25,000, okay. And do we think those are divided up roughly third, a third, a third?
Excuse me?
Do we think those are divided among the 3 MCOs, about a third, a third, a third, that they'd each have? Like
In theory, by the
8,000.
attribution approach, in theory, that would be true.
Okay. So this is, the case management issues is also a big issue around being ready to go. And it's probably the one thing that we've heard the most from consumers over the last 6 months about, geez, can I keep my case manager? I like my case manager. I've got a complicated set of circumstances. They know me. And this has been stressful for people around that. So I know that we are required to ensure that there's a relationship with all 25,000 of these people. So as we've kind of dismantled our current case management system, we know case managers have been hired away by the MCOs. We know of companies that do case management that aren't in business anymore. And I think if you're in the case management business in Iowa, you're like got one foot on a banana peel and another one trying to figure out what to do. So it concerns me that with all the change in just the people that do this from vis-a-vis employment. So can you help me understand how the transition's going in this regard? What percent of people, because we just reassigned all these WellCare people, what percent of these 25,000 have been assigned? I assume they all have, but what percent has been assigned a case manager, given the fluidity? They had a case manager. That case manager might not be working for the entity they worked for, and the capacity's going down, and those 70 case management providers you talked about, I assume their capacity has dwindled just because of this really dramatic change. Anyway, could you talk to that? And then what percentage of people have actually been, it's not only assigning somebody, but that beneficiary needs to have been contacted also by the MCO. Okay, so do we have percentage of how we're doing on that? Because this is one of the huge indicators of whether we're ready or not, and it's not clear whether we are.
We will have to get you percentages, but let me walk you through what the state has done to get ready for this, because as you're right, this is very important to us, the state, as well as to the members. So, as I said earlier, we reached out to all 70 of those agencies with the members that were assigned to those agencies. Asked them questions as, are you going to continue in case management, or are you not going to continue in case management with our members? We have a list of the case managers, companies that are going to stay, and with which members they are. We've also sent a letter out to all of the members who have case managers, letting them know that they will be outreached by the MCOs for that transition. So if they're in a current case management agency that is staying and continuing their case manager, and that member wants to keep that case manager, the MCO will be contracting with that case management agency and extending that relationship and continuing that relationship with that member. If there's a case management entity that is no longer going to be serving, or to use your term, going out of business, we know which of those members will be impacted and which MCOs they have been assigned to. And we are having those MCOs reach out to those members and align with a new case manager, because that agency will no longer be in existence. And then, so we are doing an awful lot of one-on-one support between the case management entities and our MCOs to ensure that there are contracts in place. And if members want to continue their case managers and those case managers are staying in business, we're making sure that that transition occurs so that can occur and happen.
So if I have a case manager with, say, a county government or any provider, and I can keep them, but does it require that entity sign a contract? What if the entity that's providing case management is not willing to sign a contract? How will they continue to be paid? Or are they existing case management organizations require, if they're going to continue to do case management for people under the notion I can keep my case manager for 6 months, if they don't sign an MCO agreement with any of the MCOs, how does that work?
My understanding is that when we called all the case management agencies, Mickey said 70, that all of them were, the ones that we called were continuing in business, and there would be a contract between the MCO and that case management agency for that function.
In all the cases, you said they will get contracts.
Yes.
Okay, thanks. One final set of questions on provider rates. We met with a group of providers recently that provide long-term care, intellectual disability services, residential services, and a lot of concern about how the rates were established. And I know you guys are aware of this and trying to work through this. And I don't know if it's agency by agency or more broadly, but the establishment of a rate floor using really kind of dated cost information. And in the case of a provider in my community, they were looking at losing about $40,000 a month in the services they provided. They would provide to people that essentially are in long-term care settings, ID persons with intellectual disabilities. And I know that there were a handful of providers in the same place. These are agencies that have a difficult time hiring people and keeping up staff because of low wages and $40,000 a month is a huge deal. And I'm just wondering if you can give us an update today on whether that concern is being addressed. And I can give you more, you have the details, I think, because you've been talking to folks about this, but it isn't clear to us whether or not we've resolved that. I mean, these are providers that take care of hundreds of individuals, they employ, hundreds of people, and we want to make sure they remain solvent.
We have been working on rates with various providers, and we know that those providers are actually signing contracts with the MCOs. So those rate issues are being resolved, and contracts are being signed by the MCOs for those providers.
Can I just follow up on that? 2 weeks ago, we met as a group, or actually I wasn't there, but the staff met with them, and they still haven't had any response on that, and that was 2 weeks ago. So, and we had started that process earlier. So some have still great concerns on that. And we're talking large service providers that are really going to be dramatically impacted across the state. And especially, we're not sure that, just saying that the MCOs are working on that, I think they were asking more for your interaction. And my understanding in that meeting was that you were going to get involved and be helpful to opening that up. So, and that was 2 weeks ago, so.
Yeah, on the same point, I mean, we've heard from the providers that the rates that the floors are essentially the rates, and that the MCOs don't have any, it's your call, not their call. So to suggest that the providers are signing contracts doesn't help. If in fact the rates that we've established, our people are losing money and going to go out of business. So I think the department does have some ability to address this, and I hope that we don't get to a place where we're going to be going to the MCOs to solve our problems. We look to you to do that.
Just a couple of comments, starting with the floor. The floor was established so that an MCO could not go below a certain level. So there was an effort to arrive at a level of assurance. A number of providers did raise concerns. Our contracting and financial people met with a number of MCOs with a criteria as to where we might work with them on adjusting rates. I believe this was 2 or 3 months ago. I believe about half of those, my memory was 15 to 20 did request that review. About half of those were adjusted in rates. We have continued to be available to sit down with providers that feel that their specific situation is unfair, where there have been concerns about using your example, $40,000 to actually look at those financials with them. We're still available.
not all these providers, but some of these providers also provide health care to everybody else in the community. We're not just Medicaid beneficiaries. So I think it's to everybody's benefit to have good providers, and I sure hope that the department retains their authority to make sure that things are done well.
I hear that. I agree with it. I take responsibility for that responsibility. The rates, ultimately, a rate is a negotiation between an MCO and a provider. The department is not saying you can't go above, that is a negotiation. So the department sets a floor. The department has in no way said, that's it. So that's if that's what you've heard, no, we have certainly not done that. In fact, we consider it a floor, and the development of the network is leading to funding for providers that is clearly above that floor. Individual MCOs have their own places where they start and stop and style. Again, the overriding responsibility of the department is to assure that those three MCOs create a network that is accessible and quality for our members. That's our ultimate responsibility.
Senator Mathis.
Thank you for coming today. We talked with CMS about 2.5 weeks ago, and a couple of things that they said to us, I wrote down under communications, so this would be under number 1. They said they're really doing analysis on what you're doing makes sense, but how well are you doing it? So those are the metrics, right? So out of those 16 metrics, even though you've written completed on your plan, and in talking to CMS weekly, sometimes twice a week, have they given you the finality or said, okay, you've reached that metric, move on to the next one? Which ones have they said are completed to them? And I'll just leave it at that. What have they said you've completed? They told us number 15, pharmacies, but didn't say anything else about any of the other metrics.
They have told us that the ones that they continue to monitor for us are the network, which are, let me grab this sheet for you really quick. Communication is completed, but they will continue to monitor it. The call center is completed, but 4, 5, 6, and 7 is network. Of those, the one that they're really monitoring for us is 5, and that's the development of our network. And then long-term services and supports, which is 12 and 13. Particularly 12 is the one that they are monitoring for us right now. And those are the calls that we were having, is about the network adequacy, and the long-term case management are the ones that and then the contract is completed because it's with CMS.
So you've identified the spots that are thin, that you know where you need to be a little bit more robust, and so about 4 or 5 out of 16 then, that you
Well, there are
think.
2 major categories. That's network
Right.
development and the long-term services and supports. We continue to have conversations with CMS that they're completed, but they need to see more robust of a network for us, which we have reached now. In terms of, at this point, we have the provider network that we have provided with you today, and they continue to monitor that with us and have conversations with our network.
Okay. WellCare. When we talked to them, too, they said, we have been concerned about the $135,000 assigned. Those individuals need to be reassigned and told and folded into the network, and analysis and do plans to have capacity. They said our concern is the short period of time to February 17th and people making a decision. The networks were thin, tough to make a decision. He said we have continually raised our concerns about this, and the ripple effect that will generate more phone calls, a little bit more confusion and decision. And then they said, we want to see a new analysis included in the LTSS individual. That's another thing. Can you describe, coming up tomorrow, can you describe how well you've handled this WellCare, then the WellCare transition of people? And what, compared to what they were saying, how do you see it?
So with the WellCare, we did reassign them based upon the algorithm that we have used. Now, keep in mind, there were some of those members that had already chose their MCO. So we sent those individuals that had selected their MCO a letter saying, we're going to confirm your selection of this MCO. For those that have not, that they would have choice, again, till February 17th to select their MCO. We then scripted all of our call centers to be ready for questions specifically towards WellCare members and individuals. We identified those WellCare individuals that were part of our long-term services and supports case management. We looked at them like we looked at the rest of our case management members and made sure that the calls with those agencies also identified the need for them to transition with their case management as well. And we've communicated all of these strategies with CMS and continue to have conversations with them regarding our strategies for communication for those members.
Okay, so it's ongoing. It's ongoing. All right. We're doing this live stream, so we have a question from our viewers. This is from a director of Keokuk County Public Health. She says approximately half of our clients have not received any letters of assignment according to what they have told us. We have also had claims denied by IME when we were informed that we were to bill them after January 1st since Magellan is no longer contracted. So what do we do? So the first one is clients who haven't received any letters of assignment, and maybe how you're addressing that or how you're finding these people, and then the Magellan IME issue.
Yep. So on the first issue, final assignment will be on February 17th. You know, tentative is assignment. We will be sending out letters after that date, but not before. If members have not received their packet, they've called Member Enrollment Services, and we've sent them out new information and new packets as they needed them. So that's how we're addressing that. So if there is individuals that need a packet, they just need to call Member Services, and we can get them the information. In terms of the billing with Magellan, there has been various agencies. Some of them did not enroll with Iowa Medicaid. We had to outreach to over 3,500 behavioral health providers for the transition to re-enroll into Medicaid in order for them to bill. We know of several hundred that did not re-enroll with Medicaid. If they don't re-enroll, we can't process your claims. Other issues were ownership and disclosure information were missing, didn't have that information. So as we learn of providers that did not enroll with Medicaid, on the backside there was an IT issue. We bill differently than what they're used to with Magellan. There could be a change in a taxonomy code. We reached out individually with those providers and worked with them to ensure that we could process their claims. And we continue to have providers that are having those opportunities, if you will, in terms of either they didn't fill out what they needed to enroll, or we have an electronic issue with them billing differently than what they're used to with Magellan. And we work with them quickly as possible because we do know that being able to pay those providers during this transition is critical to them. So Provider Services has been walking almost individual providers through either an enrollment issue or an IT coding issue, and we're processing those on a day-to-day basis.
One more thing, I do appreciate that if we do send a question to Paige or someone in your department, there's a quick response, so much appreciated where that's concerned.
We're really working on trying to turn around quick responses.
Thank you, Madam Chair. You mentioned in your opening remarks about a website where you had training videos. What is that website? Can you tell me that?
Yeah, hang on. It's actually it's the Iowa Medicaid website. It's the DHS's website.
Okay, so just if they just went to Iowa Department of Human Service, you'd find it?
Yes, sir.
All right, that's great. I was glad to hear about the communications as you talked about it. And I found this morning that we had help from places we didn't even know we had help. Even the area agencies on aging were getting phone calls on where to go and who to talk to, and so I just want to acknowledge that fact. I know there's some of the people in the audience today that, so we've had a lot of, and you've made great improvement the way it sounded on that telephone communication part. I'm glad to hear that. My question is, on the blue sheet, you know, you have FFS network, which stands for Fee for Service Network, I would assume.
Yes, sir.
Generally, that would be who in particular? Would it be hospitals and nursing homes, or is there more to that list, or who's on that list?
Yeah. So when we refer to the fee-for-service network, that's the current Medicaid network. So you would have your hospitals, you would have your primary care physicians, all of your behavioral health providers, your HCBS waiver providers. It's the entire Medicaid network. It's
Okay.
it's because it's fee-for-service, and that is what that refers to.
And one last question. Of the 3 MCOs, do you have a good feel for how many staff they each have hired to be ready to begin this process? mean,
I do have that number, and I can get that to you. I didn't bring that
yeah, I
with me, but I
realize that, and
can
that'd be
get you
great.
to, I can get that number to you.
Okay. I think that's all I have, Madam Chair. Thank you.
Thank you, Madam Chair. Thank you for the presentation. I guess I got a little confused, and I appreciate Senator Mathis asking this. The status and all these says completed. The question to me, though, is if I called CMS, would they say everything's ready to go and everything's marked completed and we're going to move forward March 1st?
Couldn't speak for CMS. I don't know how they'd respond to that. What I do know is that we have agreed on.
So we really don't know.
We believe we are ready March 1st. We are in a daily communication with CMS on different areas, and our plan would be to move ahead March 1st. What CMS, I believe, would tell you is where Mickey has identified areas that are, quote, completed on the 16. I believe that they would share those same completed areas and would tell you that the 2 areas that are being monitored the most closely are system adequacy and how we're doing and moving ahead on the transition on case management. But those are the 2 that we discuss the most fully.
Okay, so that's, everything says completed on the sheet, though, so that's inaccurate. Everything isn't really completed, or they would have said, CMS would have called and said, it's all completed, we can move forward now, I assume. But that hasn't happened, right?
What CMS has said relative to that sheet is that the areas that we have said are completed and that they are
But
monitoring.
all of them, it says all of them are completed.
Well, and we are.
That's not accurate.
Okay, they are monitoring with us the network development and the case management area. That is what the 2, they have accepted our plan on those 2 areas.
Some asterisks here, but really you couldn't say in progress or we need to get this done or whatever. And we're trying to get a really accurate presentation here, where we're at and what we need to do before to move forward. And this is just some sort of governor's smoke where we're talking about everything is rosy, don't check anything out here. This is all ready to go. But I guess some are being monitored. What does monitoring mean? Does it mean you have to complete certain things and then they'll sign off on it, or what does it really mean?
Monitored in this case, because I have not seen or heard a definitive line in the sand that on network adequacy you have to meet this. We continue to report to them and send them materials probably 2-3 times a week on the progression of the MCOs. We talk to the MCOs daily on how their progress is, and they usually have 5 to 10 additional contracts developed almost on a daily basis. The training on care coordination, it is the contracting with those 70 agencies, where each of the MCOs are on that, where they are on completing hiring of their own staff, and where they are against their training plan that has been written up and provided. So that is what we're monitoring. When is the provider network sufficient so that it meets a certain bar that CMS has set? They have not been that specific.
But, and I apologize, I guess I didn't see the asterisk here, I guess I need to get new glasses or whatever, but it should have said maybe monitoring and not completed, because if they are indeed being monitored, then that's a different status than completed.
Well, again, they have accepted
So I
the
think
plan.
we're misleading people here and saying these things are completed when they're not, when they're actually being monitored. And I think that's really significant, and that's something that should be taken away from this meeting. And then we can focus on those areas.
We will-
I have one last question. The situation where we had the actuarial person the other day who went on and on and on about how control you have and how you have all this oversight and everything else that DHS is going to do with all these things. And then today you said that the MCOs, you have no control on what the contracts are other than the floor. So we really don't have a lot of oversight.
I did not say that. I said that we have the responsibility to assure that what is in the contracts is carried out. We were talking specifically about the encouragement to the MCOs to sign up providers, and I was trying to make the distinction that we can go a certain degree, but I can't tell them how much they can pay, but they have to pay at least the floor. So it's a very specific area, and I did not say that we did not have oversight. I said that ultimately it is the responsibility of the state and the department to assure that we have an adequate network that is both accessible and one of quality. And where we don't feel that is in place, we will deal with the MCO and try to address that, as we have with concerns that have been raised both by you, the legislature, and the many people who do call and share their concerns with our call centers.
So what oversight control do we have on the contract to MCOs if we feel that they're way out of line and what
We have everything from putting in place a specific plan of correction, and we ask for clarification on a regular basis on how they're going to meet the standards that have been set out, and we have the capacity to fine MCOs if they have not met certain standards.
So a plan of correction
That's built into the
or,
contract. Pardon?
I'm sorry. So a plan of corrections or fines actually could be used if you found that they really weren't.
Absolutely. It's
Right.
built in, that's built into our understanding with one another.
All right, thank you.
Thank you, Madam Chair. I apologize for a second time, but thanks for the opportunity to ask a few more questions. Is it correct to say that the number of providers has doubled since December 31st? I want to get back.
It's the number of contracts that have doubled.
Okay. So were we ready on January 1st?
We are ready on January 1st and we're ready on March 1st.
Okay. How many children are enrolled in Hawkeye?
Approximately, hang on. Right around 36,000 children.
So 36,000. Have those families been assigned to MCOs?
Hawkeye is different. Hawkeye is what's called an opt-in program. And that is that the member family has to opt into an MCO. If they don't opt into an MCO, then those families will be assigned. Whereas Medicaid is an opt-out program where we tentatively assign a member, and if the member doesn't want that MCO, they opt out of that program.
So where are we on that?
We have about 50% of the families that have opted into an MCO. And we will outreach then to the other percent, and we will assign them with an MCO.
Is that going to happen before March 1st?
Their timeline is right in line with the Medicaid timeline, which will be February 17th.
Okay. So we weren't ready on January 1st. Were we?
I believe, sir, we are ready on
Okay,
January 1st.
all right, I just get to that. Do you know, and I'm just speaking for my region, whether the systems in Sioux Falls, Rivera, and Sanford are going to be part of this, since they're located and they're headquartered in South Dakota, but serve hospitals and clinics all throughout northwest Iowa and southwest Minnesota?
We do know that Avera has signed contracts with the MCOs. We do know the Dakota Dunes has signed contracts with MCOs. Sanford is one of those that they're in negotiations with, and we are waiting, just being updated by
right.
the plans.
You know, last week, I was acting as a school crossing guard. It felt like a school crossing guard. I haven't been one since 6th grade. But I was putting up my stop sign to the traffic coming on because I didn't want this to become a partisan issue, and I don't want it to become a partisan issue, but I had to, and I'm glad that I did. Because I just have too many unanswered questions. I just would like somebody to explain to me how I can go home Friday, go to the wellness center, the director of nursing, the administrator of the hospital, someone out of the clinic, one of the docs out of the clinic, know that I'm there, and they go out of their way to come thank me for my vote to at least put a stop sign out last week. I come from the third most Republican Senate district in the state. We are conservative people up there. And then, you know, it continued Monday. Today, faith leaders were thanking me for my vote. And I don't want this to become partisan. Just want to make that statement. So 3 of us voted on the Republican side that we really thought that we needed to slow this down. So I'm coming around that question. I'm going to make that comment. Because I don't understand that. If this is such a great idea, why are my providers, well, as well as patients and clients? I mean, I went to a town hall meeting in Emmitsburg, and the most conservative people who show up at that are saying, thank you. They've got people, the people and their families, or they're receiving services themselves. Here's my last point. Why was the legislature left out of this last year? Why? I really feel like we were just left out. Thank you, Madam Chair. If you've got an answer to that, that'd be fine, but I just want to know why we were just left out. I've been at this for 18 years, but this was a time when we were left out.
I think the director can answer that.
Can
It's probably not
Director
something-
Palmer, can you answer that?
I would answer that by saying the legislature voted for an appropriation that included savings related to managed care. I think the question of left out may have to do with the level of detail that the legislature was engaged in the development of the program. So I think left out becomes a term that has a different meaning for different people, and different people would not agree that you were, quote, left out, and obviously you felt you were.
I believe some of the discussion, when we asked questions, we were told that it was in an RFP process and that you couldn't give us answers to some of those questions that we asked, and when we asked to be a part of it, as I recall, and there were other members in the room on that as well. We did try to become involved, and we were told that there was an RFP process. Thank you, Senator Johnson, for those comments. Representative Heddens, welcome to the Senate hearing.
Thank you, Madam Chair, and thank you for allowing me to ask a question in your meeting today. This comes off some comments that, listening to my Senate colleagues that have been asking. Mickey, if I heard correctly, you said that the original WellCare designees should have received a confirmation letter had they changed previously. So would they have received the second one? And I'm looking back, for example, my own son, I have a son with an intellectual disability, was originally signed to WellCare. We switched and went to a different managed care company and received a confirmation letter from you back in January or February, whenever that was, December. Was I to receive a second one?
No, if you've already received a confirmation letter for that choice, you would not have to have done anything else.
Okay, so then that leads into my question. I've had some constituents contact me and others throughout the state who have contacted me who did something similar that I did, who had assigned to WellCare, switched to somebody else before the first of the year, received a confirmation letter that they switched, yet just got notification that they've been identified or assigned to a different managed care company. So now they're confused as to, well, I thought I got my confirmation, but now I'm assigned to someone else. Do I have to go through a whole new process again? I don't know how widespread that is, but I want to make you aware that that is an issue out there for some folks. You also mentioned about the case manager assignments. So I know a number of case managers who have been scooped up from the local county case managers and who are working for the managed care company. So not everybody's going to be able to stay with their current case managers. Are they receiving some sort of letter to say, hey, do you choose to stay with your current case manager, or your current case manager has left and has gone elsewhere? How are people knowing if their current case manager's around or not?
There was a communication out to the individuals who have case managers that the MCOs would be contacting and working with them. And if they, to your point, your example of, let's say they've been scooped up and that agency no longer has that case manager, they will have to select a different case manager, and we're working to make sure that there's a transition. If they have a case manager and want to continue with that case manager, then we're working with those case management agencies and the MCOs to make sure that there's contracts in place to ensure that happens.
So when are families supposed to hear from that? Again, I'm going to draw on my own personal circumstance. I've had no contact. If this is to start March 1st, I've had nothing on that. So I know, talking with the parents in my son's group home, have received nothing on that. So that seems to be kind of another issue out there. And then my final question out there is, along with what Senator Mathis was talking about and others, is we've talked with other provider agencies who have not been receiving payment. I just received an email the other day from my hospital who has not been receiving payment. If they're on a suspended, I guess right now, as you're moving with this transition, is there a time frame when they're going to expect to receive payment?
Actually, your hospital was just paid yesterday. Their issue wasn't related to managed care, wasn't related to the transition. There's implementation of the Affordable Care Act. There were certain criteria that needed to be completed and filled out by that hospital. We made sure that we walked them through that process and processed all their claims and their payments. There's a whole host of other opportunities beyond the transition and beyond managed care that has also been playing into some of the providers' delay in payment. And we're working through those one-on-one, and we appreciate you bringing that to our attention because they have been taken care of.
Well, I appreciate that, because I just think there's a lot of confusion around the whole system of what we currently are at and what we're changing to, and with all the different programs that are, different streamlines that are in there. It's very confusing for everyone. So thank you, Madam Chair, for allowing me to ask a couple questions today.
Senator Mathis?
Chair, thank you for allowing me a second round of questions. 2.5 weeks ago, again, referring to the CMS call, Mickey, they said, and this was Jim Golden and Tim Hill both said, I asked them point blank, if you had to make a decision today, and this is 2.5 weeks ago, they said the networks were not adequate, and they were seriously concerned. Quote, seriously concerned. So I understand that you have to say, January 1st, we were ready. That's your job. You're the director of IME. But CMS is saying something very different to us, and I doubt if they're saying anything differently to you. So that's case in point. The second question I have is from the audience, again, from the live stream, is so is CMS okay with the ombudsman? Meaning, have they given you the green light where the ombudsman is concerned, and what have they told you to change there other than setting up onboarding and training?
The two criteria for us were that we had to ensure that there were policies and procedures in place, and that we had to ensure that there was training. We have done both of those for the Ombudsman's office. So we've met that criteria.
I have another question on the ombudsman. You stated that in the past we had said that the appeals process was going to be the same, and at this hearing, you just said that you were meeting with the ombudsman and going over the different appeals processes for the different MCOs. So,
The appeals process is the same, but just like you and I with our insurance, if we have concerns within that, and just like with Magellan and Meridian, they have an internal appeals process. We want to make sure that the ombudsman understands the MCO's appeals processes, the internal processes they have, and then, yes, the state's appeals process is the same. So I apologize for the confusion.
Volcom.
Thank you, Madam Chair. Just quick comment. So, just history is interesting, right? I mean, we arrived back here last January, and it was announced that the governor announced that he was going to make this unilateral decision. If we could have stopped him then, we would have. We didn't have the authority to do it. Throughout most of the session, we asked for information, but because, as Senator Reagan pointed out, that you were working on the RFP, you weren't able to talk to us about what you were doing. We did pass a budget. The governor said we'll save some money here maybe, but, as people who work on the Medicaid budget know, we make the best guesstimate we can on how much Medicaid's going to cost, and as people know, we need a supplement. We weren't very close. We need apparently a supplemental of $80 million to finish out the current fiscal year, which ends June 30th. So to suggest that I've heard this, I've heard it several places, that we passed a budget, and therefore we agreed to this radical idea to turn this $4 billion over to these private companies. I don't think the record would support that. So I want to make that point. If we had not passed a budget, we couldn't have adjourned. So I think we did what we needed to do in governing here to do that. So I suspect there'll be more savings proposed this year, and we're going to pass a budget this year, but we need to pass a Medicaid budget every year, and we'll do that. In terms of the readiness question, I assume, Mickey, when you say you're ready, that DHS was ready. Consumers weren't ready. Providers weren't ready for the January 1, and certainly the people that were assigned to WellCare were not ready, because we just reassigned them in early February. So appreciate you have to kind of do it for the team here and say you're ready, but I'm hopeful that CMS will give us a little bit more time. I think it's been good for providers and consumers, and I bet it's actually been good for the MCOs to have a few more weeks to get people signed up and get their ducks in order. I hope that CMS is going to give us even a little bit more time to make sure that when this does go live, it works well. Thank you.
I'm a little bit back on the appeals process. You're telling me the Long-Term Care Ombudsman's Office has had training on?
Part of our training that we have with them, yes.
So they have experienced the training?
We can actually, if you want, we can provide the calendar of scheduled trainings, if that would help.
No, I'm just asking if the Long-Term Care Ombudsman's Office has had training on this.
On members, I believe so, yes, or it is within that calendar of to be trained, but we have a whole litany of trainings that we have
Well, you're
aligned.
meeting with them weekly, so I would
Yeah.
assume that they have. You're saying, yes, they have.
I believe so, but I would have to look at that training calendar, which I don't have with me, but they will be trained on it or have been trained on it, yes.
Okay. Somehow that doesn't surprise me.
Okay, well, I'll just close with, this has been very informative. I agree, Senator Bolcom, we are where we are, but it could have worked a lot better. I really believe that. It could have worked a lot better starting last year. And we have to move forward. But just understand, and I think you do, that we're representing, each of us here is representing 60,000 people. And a large number of those are receiving these services and have come to us confused, resistant for some of the providers. And I just continue to care, we all do, for those who are the least among this group, the marginalized, the disabled. There's going to, this is going to be a real challenge, and I want to do this the right way. And that's how we do things in Iowa. So I appreciate the work you put into it, but I wasn't really talking about whether you were ready. It's whether everyone we're going to serve. Were we ready? We were not. We were not from that perspective as an entire state. Thank you very much.
I want to thank you for coming. One of the things that still sticks in my mind, and Senator Johnson and I have been kind of sidebarring and talking about this, is that you said that the provider network has doubled since December 31st, and you feel you were ready. I mean, I just think that just sort of says so much. I mean, I don't expect a response on that. It just says that's not real. I mean, when we're talking about a provider network yet that isn't ready, if we're talking December 31st, you've doubled to now, I mean, that's huge numbers. But I appreciate you coming before us. I'm sure we'll be continuing to visit on this subject. And I appreciate all the members that are engaged in this because it's important. Director Palmer, you have comments?
Just a comment to Senator Johnson. I very much appreciate the fact that all of you representing the people that you do are receiving lots of calls and lots of concerns. We would be more than happy to meet with any one of you on any clarification, one-on-one. That's an ongoing offer on any of these subjects, and we would be led to meet with your given providers on specific issues, and our call centers are talking to your constituents. I get calls regularly from constituents as well. So the more that we can make ourselves available, and I do appreciate the pressure that you all are feeling, because I certainly get calls for clarification as well.
Some of our providers that have been coming to us don't have the internet. Some of the providers that come to us are very low income and very confused. Senator Segerbart and I were in another sidebar. We're talking about the confusion that I've seen. People have come to my forum and left saying they have no idea who to contact. And while it may seem simple to us, it isn't to them. And it also, you know, the appeals process, I mean, that's down the road, but just signing up has been so confusing. I can't imagine what's going to happen when we get to the appeals process. And so we're looking at how we protect consumers and providers so we continue to give good health care across the state. So at that, I would say that we're going to adjourn, and if any of the members have any questions afterwards, I'm sure they will find you. Thanks again for being here.
Thank you.
Thank you.